Thank
Yes.
you very much, Salome ma'am, for the kind introduction, and Dr. Geeta. And I think I'm also one of those people who's very, very keen on, dispensing knowledge on nutrition. And I can't, say how important nutrition is in children. I have always thought that, it is something that one needs to focus on much more than what we are doing now. All this. So last time actually we spoke about children under 5 years, and you might recall we said the first 1,000 days are important, which is until 2 years of life. After which, between 2 to 5 years, also we said that the growth rate is quite rapid. Now, what normally happens is up to 5 years of age, there are the immunization schedule is ongoing, so we actually opportunistically measure children when they come to us. And the thing about a child is that if you monitor a child's growth, a normal child's growth, then you are able to say that the nutrition is going okay. So growth can tell you a lot of things in children. And hence the parameters that we use most commonly to monitor nutrition is growth. So if you look at, children older than 5 years, so we monitor growth as an essential part of child surveillance. So if you walked into our unit with a child, first thing we do is measure the height, weight of the child and plot the child. Because if actually a child's growth is normal, most things are going okay in the child's life. Now, growth monitoring alone has been shown to improve children's health, nutrition, and reduce mortality and morbidity across the world. And that is the reason why we do it. Now, I showed you this slide last time. So we call it the ICP model of growth. That is the infancy, that is up to 2 years, the childhood, that is up to 9 years, a little older in boys up to 11 years, and then the puberty. So different factors are actually responsible for the growth in these different phases of life. Like we said last time, in infancy, it's almost entirely nutrition. In childhood, you have some hormones coming in, like growth hormone, thyroid hormone. But as you can see, here also nutrition is important. And then if you look at puberty, if you look at this part of the growth spurt, this is the second rapid growth spurt in a child's life. So at that time, children grow anywhere between 10 to 15 centimeters in a year. And at that time, the sex hormones are also very important, which is the estrogen in girls and the testosterone or androgen in boys. So that is the reason why even after 5 years, you need to keep monitoring growth. You can't just, so what normally happens is in clinics when children are brought in, or when a child comes to you for consultation, normally picky eating, difficult to eat, not putting on weight, you generally find that these children only come till 5 years of age. But after that, very few people tend to monitor growth, which is not the right thing to do, because you can see you're going to miss this growth spurt. And there are also many other things which we will discuss as we go along. So what parameters do you often choose when we monitor growth, and are there any guidelines to follow for Indian children? So just to remind you, what we said last time is that we use the World Health Organization WHO growth charts till 5 years of age. Now, what happens after 5 years of age? So, which anthropometric parameters do we use after 5 when the child is older? You might recall last time we said that in babies or children up to 5 years, we use mainly height, weight, weight for height, head circumference, and MUAC. So these are the 5 things that we commonly use. There are, of course, more indicators, but I think you can get away with 3 or 4 indicators. Those are enough. So what do you do in an older child? You obviously do a height, you do weight, and instead of the weight for height, here we use BMI. So that is the body mass index, which is the weight divided by height square in centimeters. Now, we'll also look at these, that for certain specific conditions, you need to know different parameters, and this includes the height velocity, which is the growth rate which I spoke about last time also. I will remind you a little bit about it. Then the upper and lower segment, then you have the waist circumference and the MUAC. Now here I'm saying for certain conditions where the child is not very sick. For sick children and for nutritional screening or for the at-risk population, we are going to discuss in our next lecture. So let me remind you what we said last time, that is for little ones under 5 years of age, generally we measure the child at the time of immunization, that is birth, 6, 10, 14 weeks, 9 months and so on. And additionally after that, every 6 months a child is measured. But what about later, what about after 5 years of age? So generally we advise that though we have said in the guidelines that it should be 6 monthly, anywhere between 6 months to 1 year for recording height, weight and BMI for a normally growing child is okay. But if a child is not growing normally, you may have to measure the child even every 3 months, because if you wait for 1 year, the child has actually fallen back by 1 year. So once again, which charts do you use? So we know that earlier on we used till 5 years, we used the WHO charts. They have been adopted by the Indian government. Now after that we use the Indian Academy of Pediatrics growth charts. Those charts are from 5 to 18 years. Now you will say that why do you use World Health Organization charts before 5 years and after 5 years you use local or ethnic specific charts? That is because children in different countries do tend to grow differently and it is affected by the environment. So you can't really control the environment of an older child. Like in a 2-year-old, it can't go off and have, a hamburger or a vada pav or whatever. But in an older child, you can't really control the environment, and it is very much decided by what the environment is. So what we used to find is that if we used Western charts for our children don't really grow that much during their pubertal years. So we used to get our calculations wrong. That is why we embarked on this study. And finally, in 2015, we came up with the revised IAP growth charts. What these do is till 5 years of age, they advise the WHO charts, which we talked about last time. And after that, we use the local Indian charts, which are also freely available at the IAP website. Just to remind you that these are the charts that we actually use in little ones. Once again, blue for boys and pink for girls. This is the WHO chart for under 5 years, age in months. This is the other parameters. So here is the lowest is the weight, the one in the middle is the head circumference, and the one on top is the height. Then you may recall that weight for height is the parameter that we use to diagnose MAM and SAM. So moderate acute malnutrition is when a child is between the -2 and -3 SD, or if you were using this chart between the orange and red line, and severe malnutrition is SAM is under this. So this was just a reminder of what we saw last time. Now what do we do in older children? Once again, we use the same convention, blue boys, pink girls. So here we don't actually have a head circumference chart, because you can see that this is the weight and this is the height, this is the age, and this is the measurement. So the reason that you don't have a head circumference here is that the head circumference does not change very much after 5 years of age. So when you want to plot a child, you plot the child according to his age, you plot the child here his weight, you plot his height, and then you read the reading to see whether, so there is another slide which I will show you again, once again, to remind you what is normal, what is not. Then what about, malnutrition? So in older children, we use the BMI or the body mass index. So anybody who is under this line is malnourished. So there is no definition of SAM and MAM under 5 years of age. These are over 5 years of age. These are definitions that you use under 5. And as you can see here, above this is overweight and over this is obese. So these charts are actually the ones that we now use for older children. Just to remind you once again, this is very similar to what we saw in the WHO charts. So the lowest line is the lower limit of normal. The top one is the upper limit of normal. So what we say is the child should be somewhere in between. And similarly, for the height, this is the lowest acceptable and this is the highest acceptable. So you may remember last time we spoke about this, that what you like to see is multiple readings, and what you normally see in a child after 2 years of age is that a child sticks to his or her trajectory, as it is called. So this is the average. So if there is this boy who is 9.5 years old and he is here, then what you would like to see is to see him continue on this line. We spoke last time that if a child crosses 2 centiles, so a little one was here, but next time you see him, he's here, he's crossed 2 centiles, then it is dangerous. Similarly, he was here, but he has gone down here, that too is dangerous. But all this is if you are lucky enough to see the child multiple times. Many times children just appear once and totally disappear when you say that whatever these tests are required, or you require this treatment, or you require this counseling, patient will disappear. Now, similarly for the height, this is the average, this is the upper limit, and this is the lower limit. So one question which many people ask us is, why isn't only the average plotted? That is because this is a range of normalcy. You might have a man who is around 160 centimeters. He is also completely normal, and a person at 180 and 185 also might be completely normal. It might just be his genetic potential. That is why we stopped doing only the average. Now we have this range of normalcy because these are biological parameters. Now, if you look at these charts, I'll just tell you a little bit, don't worry about it too much. This is the BMI, that is the weight for height, the counterpart of weight for height in older children. You require a BMI to say whether a child is overweight or he is obese. Now, these are actually have been constructed based on adult equivalent. So what this means is that if a child who is around 7.5 years is here, then as he grows older, even if he sticks to his same trajectory, he will actually have an adult BMI in the obese range as per the Asian cutoffs. That is why these have been taken back, and so the BMI cutoffs are a little lower for Indian children, just as they are lower for Indian adults. You must be knowing that the BMI cutoffs in the West are 25 and 30, but for Indians, because we have a higher amount of body fat for a given BMI, our BMIs have been brought down to 23 and 27. Similarly, the children's BMIs have also been brought down. So only thing you need to remember is overweight and obesity. Now, when you're assessing growth and nutrition, you need to use growth charts, and charts are much better than tables, because if you have a table, how would you interpret it the next time the child comes? So if you are lucky enough to see a child multiple number of times, which is what is really advised. So longitudinal data plotted over a period of time is much more valuable, and then it is very hard to interpret these data through tables. For instance, just look at this girl. So now this is a child with Turner syndrome who came to our clinic. Now, Turner syndrome is a condition in which a girl's ovary, for whatever reasons, actually fails. And these girls tend to have overweight, as well as they are short and they don't go into puberty. So you can see we have plotted her growth chart here. You can see that her weight is going up. So the increase in weight is not as much. So if you look at the child, she looks chubby. But if you can see that her height is going down, so she's not having a pubertal growth spurt. As you can see, this marking is around 11 years of age. And here she's really not, she's actually losing height. She's losing centile. So this child, you can see, is now overweight for her age. So if I were to plot her on a BMI chart, I will see that she is in the overweight or obese range. But the only reason why I showed you this is to show you that it is very important to measure longitudinally. Now, we discussed last time that how does parents' height impact a child's height? Okay, so before I go down this path, I just want to tell you that often till 2 years of age, the children tend to realign. So if you have a little baby who's born to a very short mother, so the baby's size will actually depend on the mother's size. And the reason why the nature has planned it like that is that otherwise she would never be able to deliver the baby. So even if a mom is 5 feet tall and the father is 6 feet 3, the baby will still be small. The reason is it has to be to correlate to the mother's height. But what happens is within the first 2 years, the children tend to realign. So they realign to what their genetic potential is going to be. So that is one time in a child's life when the child actually crosses centiles and it may still be normal. So what about older children? How do you account for parents' height in older children? So I mean, what would happen in this case where the girl is taller? What would happen in this case when the father is massive and the lady is little? And what would happen here? I mean, these are questions that we can answer by using a formula for mid-parental height. So we call it mid-parental or target height. And when we measure any child, we always measure the parents as well. So that is, when we are measuring the parents, we have a specific reason for that. Though the children are extremely happy because, it's not only though they who are being prod and poked. They're happy when their parents are also measured. But we actually measure the parents to know the genetic potential of the child. So how do you calculate target height based on the family's height? So essentially, this is the formula that what you do is you add the mother's height to the father's height, add 13 and the whole divided by 2 if it is a boy, and minus 13 if it is a girl. So you add mother's and father's height, divide by 2, add 6.5 for a boy and minus 6.5 for a girl. So that will give you a target height. So we normally mark it on a growth chart and we plot it at 18 years. The target range is 6 to 9 centimeters. So what this means is that if a little girl comes to you and you mark her target height, which comes to 150 centimeters, then she can be between 156 to 159 above, and even lower. It might, if you have to take off 6 to 9 centimeters from 150, and that is her target range. So this is the way you actually adjust for mid-parental height or parents' height or target height. But we discussed last time that you have to be sure that the parents have achieved their nutritional potential. So what happens, so if you are seeing a child who comes, who have just come to from a rural area, they have come to live in the city, you will find that the parents have not reached their genetic potential. Then you cannot actually judge the child's height only basis the parents' height. So this is something that you need to keep in mind. So this is how that we adjust for parents' height. Now I'm just hoping I can get this up for you. Okay. Right. So this is a child, this is a boy, and here is the father's height, mother's height, and this is the target height, which is 160 centimeters. So what you do is you mark it here, you mark the target height, and then you do around 6 to 9 centimeters above and below. Now the child who came to us is a 9-year-old and he is around 120 centimeters. So you can see that he's sitting bang on his target height. So if he continues to grow in the same way, then you will find that he is going to achieve his height potential. So this is how you actually use a target height. But once again, the caveat is that the parents should be well nourished. Another thing is that, say the parents are really, really tall. If the parents are really tall, the children tend to be a little shorter than their parents. So it is called as migration to the mean. So if the father is 6'2" and the mother is 6 feet, often you find that the children don't actually attain their target height. They can be a little shorter because what happens is that nature tries to get you a little closer to the mean when you're that tall. So now you have to use a growth chart. You need to calculate the BMI. You need to look at the parents' height. How would you do all that? So we have made this a little bit easier for you. So we have actually published a paper, which I think was last year. So we have added some tools for you. This is a mid-parental height tool, and this is a BMI tool. So what the mid-parental height tool does is that on this side you have father's height, on this side you have mother's height. So what you need to do is look at, say the father is really tall, 187, the mother is also very tall, 174, then you just need to join this line here. You need to keep just a ruler here, and you know that the child should be on the 97th centile. So you expect the child to be somewhere on this line or a little bit above and below that. You now know it's 6 to 9 centimeters. So this is a MPH percentile calculator. You don't have to remember all those words. Just remember that there is a tool available where you can look at the father's and the mother's height and just look at the centile. So where you can see where the child should be. Similarly, we have also put a BMI tool on the same chart where here is the height, here is the weight of the child. What you need to do is, if a child is 125 centimeters tall and say he is 40 kilos in weight, then you just have to mark the child here, and you know that if the child is above this line, that the child is obese. So we have added these tools just to make it easier in a busy clinic or in a busy consultation, so that you can give your time to the counseling rather than to the calculations. Now, once again, a reminder that when you take height, make sure that your eye level is at the level of where the reading is. The height is an indicator of past nutritional status, and it is relatively insensitive to rapid changes in nutritional status, for which you need weight and you need BMI. So you need BMI because it has to be tempered by height. So the thing is, in a little one, you know that a baby is born at around 3 to 3.5 kilos and triples its weight by 1 year. But in older children, there is a lot of variation. So a boy might not go into puberty until 13 or 14 years of age, and another boy might be a humongous 6 feet. And then, if the weight is 50 kilos at 6 feet and 5 feet, then the BMI is very, very different. So you need to actually have a BMI in older children. Once again, a reminder of the equipment. This is called the stadiometer. This is the infantometer. This is also a portable stadiometer. And what you saw in the earlier slide was a wall-mounted stadiometer, which is the one that we use. And as I told you last time, for the taller boys and girls, we actually have stools that we can stand up and make sure that we see the height at the child's, at wherever the line is, So we have to read it exactly here. If you read it from below, you read less. If you read it from above, you read more. So you could get your reading wrong. Once again, for the weight also, that, last time we looked at the weights of the how you actually look at weight. So most people do use bathroom scales, or you can use an electronic scale. And we, of course, use a beam balance, because for research, we need beam balance. And it's an indicator of nutritional status. That is, the weight is an indicator of nutritional status, and it is very important for nutrition intervention, because in the short term, you will not see the height increasing. So to see an increase in height, generally, unless the child is on some hormone like growth hormone, you at least need 3 months. But in the weight, in a child who's very underweight, you may see difference even in a month's time. And it's very important for follow-up. Like I said right now, because it doesn't account for differences in height. Remember the height of a child who's 5 feet and a child who's 6 feet. So if the same child is 50 kilos, maybe okay at 5 feet, will be extremely thin at 6 feet. That is why you need the BMI. Now, in children, once again, under 5 years of age, you know that we use SAM, MAM, and we use for obesity, we use the upper centiles, that is +2. More than +1 is at risk, and more than +2 is obese. And in older children, as I said, we use BMI. For some reason, it has stopped responding. Yeah. So now for the use of the body mass index, that is weight in kg divided by height in meter square, we've already discussed some part of this. Once again, just to remind you that this is a BMI chart. This is the lower limit of normal. This is the average. This is the overweight and obese. And I explained the adult equivalent concept to you some time ago. Now, the reason why we use the adult equivalent concept. So if you look at how cutoffs are decided, or if you look at, how do you know, how do you say that lipids above so and so are abnormal? So normally the way it is done is that people look at, researchers look at patients who have had cardiometabolic risk, and then who have had cardiac events, and then they look at lipid profiles of those people, and then these cutoffs are derived. But the problem in children is that children don't have heart attacks. So we need to actually find out something which we can use before the child actually has a heart attack. So that is why we use the adult equivalence. Now, we have already gone through this, so I'm just going to go to the next one. So now, what are the recommended cutoffs that we use? So underweight is body mass index of less than third centile is underweight, or equivalent to 18 kg per meter square. For stunting, it is less than third centile, or 2 SD. And for overweight and obesity, it is over the 23rd adult equivalent and over the 27 adult equivalent. So these we have gone through last time, that is 0 to 5 years. And for 5 to 18 years, you mainly need to look at underweight, overweight, and stunting. So we don't normally use weight for age. You need to use BMI for age. So what are the other parameters that are important? So we discussed height, we discussed weight, we discussed BMI, we revised a little bit about children under 5 years of age. What are the other parameters that you need to use? And like I said some time ago, this is in children who are not sick, not hospitalized. These are children who are essentially healthy children, but who have come to you with growth failure. So you need to know a rate of growth. So what that means is that, I think it's there in my next slide. Yeah. So you need to see, say you have a 5-year-old who is say around 98 or 95 centimeters. So what you need to know is between 5 and 6 years, how much has the child grown? That is the rate of growth, or we call it a growth velocity. So if you were to send a child to me to say that, madam, we need a nutritional assessment on this child, we need a growth assessment on this child. So I will measure the child, and then I will call the child back in 3 months. If possible, call again after 6 months, and then give you a judgment of what is the growth rate. So if a child has grown 2 centimeters in 6 months, he is only growing 4 centimeters in 1 year, and that is way too less. So even though his current height may be normal, his growth velocity or rate of growth is very low, so he is going to fall back. So those charts actually look quite different, and they are called as velocity charts, and this is something we published, I think, in 2018. So this is a velocity chart for girls, this is a velocity chart for boys, and what you really need to know is that I think you just need a simple formula that, do you remember we talked about this last time, that in the first year of life a child grows 24 to 25 centimeters. So that is the growth rate, and the attained height is at 1 year is around 75 centimeters. At 2 years, a child is around, I think it's around 82 to 85 centimeters. So the growth rate between 1 to 2 years is 12 centimeters. And in the third year of life, the growth rate is 6 to 8 centimeters. After 4 years of life, children grow 5 centimeters every year. So say you measure a child at 5 years and you measure a child at 6 years, you will find that the increase in height is around 6 centimeters. So if a child grows less than 4 centimeters in a year, then it is abnormal till puberty. And you might recall I said to you that puberty is still around 9 years, before 9 years, 8 or 9 years in girls and before 12 years in boys. So children only grow around 5 to 6 centimeters. But during the pubertal years, that is in a girl from 9 to 12 years and in a boy from 12 to 14 years, children tend to grow a lot. So even if you have not been growth monitoring before that, it is very critical to do it during these times, because you need the growth rate to be normal for the child to attain his normal height. So if you see that the child is growing very, very less, then you actually need to investigate about what is going on. So the first stop always is nutrition. First thing, we always find out whether the child is actually eating enough. The next thing that you can see is that we look at proportion chart. So if a little one comes to you and you look at the child and you see, so you can see this little fellow, he is called an achondroplast. So they are healthy children, but unfortunately their limbs are very short. So the spine, this child's spine is normal in size, but his limbs are very, very short, and that is why he is very short. So in such children, we actually measure the upper segment, lower segment ratio, and we can tell you what the child has. So normally, this is not nutritional, but these are some of the parameters that we use to figure out whether you're looking at a nutritional problem or you're looking at something else. So we looked at growth charts, that is the distance charts. After that, we looked at height velocity charts or the growth rate. After that, we looked at proportion charts where the upper segment and lower segment. So when a little baby is born, the upper segment is much bigger. Around 9 years, it becomes equal, after which the legs are longer. So, these proportions also is something that we need to study to be sure that what you're dealing with is a nutritional or some other problem. Now, we all know that there is an epidemic of childhood obesity. That is another reason that you really need to measure children. So, if you actually measure a child, if you don't measure a child and a child becomes hugely obese, then getting a child to lose weight is very, very hard. I'm sure it is something that you nutritionists face much more. I mean, you face the problem a lot, but we have come to the conclusion that you can only prevent childhood obesity. You can't really treat it. It is very, very hard to treat. So our work and those of other scientists has also shown that every fourth or fifth child in urban areas is overweight or obese. So that is really, really bad news in a country like India. We are the diabetes capital of the world, as you must be knowing. So what we also need to do is to look at the metabolic syndrome. So we need to measure abdominal obesity, and which should not be more than the 90th centile for the age and gender. And of course, you look at the lipids. So in an overweight child, apart from the height, weight, and BMI, you will look at waist circumference, and you may have to measure the blood pressure and do some blood investigations to look at the high cholesterol, lipids, and the blood sugar levels. You may be amazed to know that quite a large number of children are also having type 2 diabetes now. Our youngest type 2 is actually 5 years old, and the situation has really grown out of control during COVID times because the screen time has increased, schools are not around, and children are sitting at home and eating. So this is really a time bomb. So we actually measured what the waist circumference percentile should be, and this is a study that we did I think we published in 2014. The study we did in 2010, but we've actually described what normal waist circumference should be in our children, in boys and girls. So these are what the charts look like. Pink again, girls, blue, boys. So you can plot the child, and we have found that the child should be under the 70th centile. So if a child is under the 70th centile on a waist circumference, you know that there is nothing to worry. If a child is above that, then obviously he has to come to a nutritionist like you to be treated for obesity. Now, the last, I think, parameter in this is the mid-arm circumference. So do you actually measure it after 5 years? So poor nutrition is not restricted to young children, and it's a major public health concern in school-age children, and also in disease states such as cancer, and in special circumstances such as in an amputee, where you may not be able to, measure a BMI. For the assessment of nutritional status, MUAC is actually used even in older children. So in fact, I met Salome ma'am in the meeting with the cancer guys and the cuddles people some years ago. So we conducted a collaborative study and collected some data from June 2018 to 19. We measured around 7,000 children from 7 schools from 7 states of India, and we have recently published MUAC centiles for older children. We have found that the lower cutoff is 25th centile, not the 3rd centile. Our children seem to have fatter arms for their given BMI, and the upper centile was the 95th. And we have also suggested from some cutoffs for these children where you can just measure the child with a mid-arm circumference tape. You don't need to do the height, you don't need to do the weight, you don't need to know the age, because MUAC is an age-independent criterion, and you can tell whether a child is undernourished or overnourished, both in boys and girls. So these are what the MUAC curves look like, but really one won't be using the curves. What one will be using is a tape, which we are making at the moment. So this is the paper that came out last month, where we presented reference centile curves for mid-arm circumference for assessment of under and over nutrition in school children. So this can be used in Indian children now. Now, how do you put it all together? So this is an example, a boy who is 10 years old, weight 37 kilos, seems to be a little high, height 138, seems to be, to me, normal. BMI 19.4, in my opinion, this is a little high, and the MUAC is 35. So this does seem to be high. So let us see what this child has. So you can see that we have marked the child here at 10 years. So the weight is on the 75th centile. The height is on the 50th centile. But if you look at the BMI, he is in the overweight range. So this is where he lies. So this is an overweight child that you're dealing with. Actually, this is a good time to see the child, because it would be better that you see him here than see him here somewhere, So at least here is something that you can, try and change lifestyle. Another thing that we have found, especially in boys, is that if a boy comes to you before he actually starts growing tall, which is around 12 years, then you can often get him into shape. You can get him into shape than if he comes much later. So this 10-year-old boy, you saw that he's in the overweight range. Then we marked his MUAC, which was 35 centimeters, which is quite high. And you marked his waist circumference, which is 90 centimeters, which is very, very high. So what you are seeing is an overweight, centrally obese child. So you can tell this only by using charts. But for this child, you actually need to do a dietary assessment, plus you need probably to do lipids, etc. You need to take the blood pressure in this child. So we saw last time that there are software tools. There is the WHO Anthro, and for older children, there is WHO Anthro Plus that is available. Are there any other tools for growth and nutrition monitoring and for researchers? So Indian Academy of Pediatrics has put together, an app for monitoring a child's growth. Also, we've put together Excel sheets where you can actually, which have formulae in that. So you can actually just put in your own data and you could get all the calculations ready-made. We have put these sheets together. My dear husband has done this bit. And to conclude, so growth monitoring and anthropometry are invaluable tools in the hands of healthcare and nutrition workers. We need to get into a habit of plotting growth until the age of 18 years. Growth charts help to assess nutritional status and reduce expensive investigations. We saw in the last slide in the example of the 10-year-old. When you suspect growth failure, remember to take the growth rate. So how much a child has grown in 3 months, in 6 months, in a year is very important to know how much the child is going to fall back. You need to use the IAP chart for 5 to 18-year-old children. That is what the Indian Academy of Pediatrics has advised. Adjustment for mid-parental height is required when assessing a child's height. You might recall the formula that we used, which we mark at 18 years. So you mark the target height, but you need to know that the parents should have achieved their genetic potential. That is, they should have had good nutrition. And sometimes in very tall or very short parents, you find that the child is actually shorter or taller to come closer to the average of the population. Obesity is on the rise. Please mark that. Any child whom you can stop from growing obese, I think one must do that. You need to use the BMI and waist circumference. Both of them is very important. If there is disproportionate short stature, one needs to assess the proportions. Of course, that is the work of the specialist. You can send them to us. In surveys or when it is very difficult to take height, MUAC is a good indicator of nutrition. Now there are charts even available for older children. Thank you so much. Thanks.